All right, let's dive into one of the most classic, high-stakes dilemmas you'll find in any emergency room. Two patients show up, both with the exact same terrifying complaint. I can't breathe. But here's the twist. One needs a treatment for inflammation, and the other for a serious infection. Making that call and making it fast is what this is all about.
So, I want you to put yourself right in the clinician's shoes. The clock is ticking. The pressure is on. Every single detail from the patient's story, every number on that lab report is a piece of a life-or-death puzzle. Get it right, and your patient starts to stabilize. Get it wrong? Well, the stakes couldn't be higher. So, let's start breaking down the clues.
First up, we've got a scenario that I guarantee many of you will recognize. This isn't about something new and mysterious. This is the story of a chronic condition that suddenly spiraled into a dangerous acute crisis.
Okay, so picture this. A 65-year-old man comes in, and he is clearly struggling. He's doing that classic tripod position, leaning forward, hands on his knees, using every muscle he has just to try and force air out of his lungs. You can just see the panic in his eyes. This is a very familiar scene in a busy ER. So we start digging into his story, and the clues just start popping up. This shortness of breath, it's been getting worse over the last 3 days. He's got a nasty cough, you can hear him wheezing from across the room, but, and this is huge, no fever. Then comes the real kicker, a 40-pack year smoking history and a known diagnosis of COPD. So right away we know this isn't a new problem. This is his chronic battle hitting a critical flashpoint.
In the lab results, they are basically screaming COPD exacerbation. His oxygen is down to 88%, and he's breathing way too fast. But the real smoking gun is the arterial blood gas. A pH of 7.32 means his blood is acidic. And why? Because that PaCO2 of 52 tells us he's retaining carbon dioxide. His inflamed airways are trapping air, which is exactly what the chest X-ray shows, hyperinflated lungs. It's the textbook picture.
So, this is the moment of truth. You've got all the data in front of you. What do you do right now? Now look at these options. They all seem like reasonable things to do for someone who can't breathe, right? But only one of them attacks the primary problem for this specific patient. So, take a second. What's your call?
If you chose C, you absolutely nailed it. The single most critical first step here is to give IV methylprednisolone, a powerful steroid, to knock down that underlying inflammation.
So let's break down the why. In an acute COPD exacerbation, the real enemy, the core issue, is severe runaway inflammation in the airways. Think of it like a 5-alarm fire. Steroids are the fire department. Now what about the others? Antibiotics aren't the priority because we don't have clear signs of an infection. NIPV, the breathing machine, it's a great tool, but we usually save that for when the acidosis is even worse. And oxygen? Look, oxygen is crucial, but it's just a supportive measure. It's like putting a bucket under a leaky pipe. The steroids are what actually go in and fix the pipe.
Okay, case 1 is in the books. Now, let's shift gears to our second case. We've got another patient struggling to breathe, but as you'll see, the clues are about to take us down a completely different diagnostic highway.
Our second patient is a 72-year-old woman. She is also short of breath, but I want you to notice the very first word on this slide, febrile. She has a fever. That one word, right off the bat, changes everything.
And her story just adds more layers to this new puzzle. This has been going on for a whole week. She has a productive cough, and crucially, this sharp, stabbing chest pain on her right side whenever she breathes in. That's a huge red flag pointing to inflammation of the lung lining. And unlike our first patient, she has no smoking history. All the pieces are pointing away from a chronic airway disease and directly toward an acute infection.
And the labs? Well, they pretty much seal the deal. Her temperature is high, her white blood cell count is elevated, and her C-reactive protein, a key inflammation marker, is through the roof. But the chest X-ray gives us the visual proof, a solid white patch of consolidation in her right lower lobe. That's pneumonia. And there's also an effusion, which means fluid is building up around the lung. We even identified the culprit in her sputum, Streptococcus pneumoniae. This is a clear-cut case of a bacterial invasion.
So we have a new patient and a new puzzle. The infection is obvious, but that fluid collection we saw on the X-ray, that's a major complication. So what's the most critical priority for this patient right here, right now?
And the correct answer here, which might actually be a little surprising, is B, perform chest tube placement. We need to drain that fluid out of her chest.
So why drainage first? I mean, shouldn't we just blast her with antibiotics? Well, here's why.
This isn't just simple fluid, it's what we call a complicated parapneumonic effusion. Basically, it's a walled-off collection of pus sitting next to the lung. Now, antibiotics are absolutely essential, but they can't penetrate that thick, walled-off abscess very well on their own. This is where the critical principle of source control comes into play. You have to remove the source of the infection. Draining that pus is the key move that allows the antibiotics to work and for the patient to actually recover.
So let's pull back and put these two cases side by side. It's pretty incredible when you think about it. Two patients, one symptom, but two completely different diseases that demanded two totally different critical interventions.
This slide just lays it all out perfectly. The presence of a fever was the first major fork in the road. Then the chest x-rays told two completely different stories. One was about trapped air from widespread inflammation, the other was about a localized infection with a buildup of fluid. Once we could clearly define the core problem, inflammation versus infection, the key intervention became obvious: steroids to fight the fire and drainage to deal with the invasion.
And that really brings us to the single most important takeaway from all of this. When a patient is struggling to breathe, you have to ask yourself, am I fighting a fire of inflammation that's spread throughout the airways, or am I fighting a localized invasion by bacteria? The patient's story and the picture from the X-ray will almost always give you the answer.
It's just a powerful reminder that in medicine, the details are everything. The difference between a fever and no fever, between diffuse wheezing and a localized consolidation, that can be the difference between heading down the right path or the wrong one. So, as you continue your journey, always ask yourself, what's that one small clue that could change the entire picture?